Good evening, everyone. Welcome to TeleShadowing. We're live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be addressed. So today we're going to be talking about the medical student pedagogy, essentially because we're going to be starting off going over some, I guess you could say, in a mini medical school boot camp sort of format over the next couple of months. I'm going over the main topics that are covered in the USMLE Step 1. And so getting this early exposure will actually help you a lot when you start medical school. So I'm currently studying for my USMLE Step 1, and so I just wanted to share a couple of studying tips and tricks and strategies, and also some adult learning theory models that I've learned throughout med school, and what's really effective, what's not effective. And overall, really, it's up to you and what your learning methods are. So we'll learn a lot more about that. And just for context, I am a rising second year medical student. So definitely midway through the pre-clerkship curriculum right now, and I'll explain a little bit more about what is pre-clerkship and what are all these terminologies. So first, I want to talk about transitions. Of course, we all had transitions when you went, or if you're currently a high school student, from middle school to high school, and then when you start college, there's a transition between high school to college, and then there's also a transition from college to medical school. So I'll start off first with the transition from high school to undergrad. This is sort of a time when you go from having everything structured for yourself to no longer having things structured. And you're also transitioning into adulthood or your young adulthood at the same time, sort of figuring things out. There is much more time flexibility. You're not in classes 8 to 3. You get to choose when your classes are. I personally learned the hard way that 8 a.m.s were not for me. 8 a.m. chemistry lecture was not for me. Instead, I preferred having my classes at 9 a.m., and that was also possible to switch around. You also have choice in choosing your professors. There's much more time flexibility, I would say, as well, because I'm in class 2 times a week, and being in class 2 times a week is actually very, very helpful in giving us much more time and flexibility to do homework, and there isn't much classwork, relatively speaking. So yes, you can also choose your major and your field of study. You don't have to necessarily be a biology major to go to medical school. We've talked about that in our medical school application series. And you also get to go at it at your own pace. You get to choose how many credits you take, whether it's 12, 13, 14, 15 credits, sometimes up to 18 or 20 credits. And there's also a difference in the learning environment from high school to college. In high school, I feel that I always had a guidance counselor or a teacher sort of following up with me. I remember when I played basketball, I had basketball coaches, of course, checking in on me, making sure that, okay, are you sure you're able to come to practice because you have an AP biology test tomorrow? So I'd be able to sort of have much more of a support system that was built in. Whereas in college, you sort of have to seek that out, which isn't too different from medical school, of course. And there's also a change in study habits and also expectations, because when you're at college, your college instructors are called professors. They're not teachers anymore, they're your professors. So of course you may already have had this transition or you've gone through it, but I know that when I was transitioning from high school to undergrad, these were the main aspects I found. I also found that people who dorm, they have much more independence, and so they're also learning how to cook on their own. They're learning time management skills now that they have so much quote unquote free time. Of course, college students tend to fill it up, especially if you are a pre-med student, juggling it with all the pre-med responsibilities, as you may already know, like research, leadership, clubs, etc. But I remember in my first semester, I was just focused on really transitioning, really making sure that I have my GPA down. I'm able to uh, test and try out different study habits and just get acclimated to my new surroundings. And then in the next semesters of my freshman year after that, I added some more things on. So let's just refresh again the path to becoming a doctor. So you've decided in college or in high school, or maybe even before that, that you want to become a physician. So this is what goes into it. Many of you may already know this has actually gone over during our first teleshadowing session, but it never hurts to have a review. First, you do university or your undergrad studies. It can take anywhere between 2 to 4 years. It depends. If you complete your associate's degree in high school, then you can also complete your undergrad in 2 years. And then there's also medical school. Medical school can be usually it's traditionally 4 years. I'm at a 4-year program, but I know of many different 3-year programs now that are opening up in the United States. One example is Stanford University, and another one, I believe, there are a couple others as well. And then you go into residency. You do become an MD, you become a medical doctor, and you get to be called a doctor after medical school, but you're not licensed to practice and, let's say, prescribe medications and do treatments yet until you have some, I would say, hands-on learning with actual patients, talking to patients. It's called post-MD training, called residency. The term residency is very interesting. I remember thinking about, like, why is it called residency, not training or clinical training or post-clinical training? The reason why is because I believe Johns Hopkins University in Baltimore, they actually they say that they coined the term or invented the term residency because they would actually, I would say, overwork their healthcare professionals and residents. That they would always that these trainees would be right after high school, would be right after medical school, sorry, after medical school, they would be in the hospital almost 24/7. They would sleep there. The ones who worked really, really hard. So long story short, they became known as residents because they basically lived in the hospital. And today it's not that different. Working hours are anywhere between 60 to 80 hours a week for first year interns that they call them after medical school. And after that, you can also do a fellowship or some subspecialty training based, and it depends on what type of residency training you did. They can, and residency can range anywhere between 3 to 7 years. There are 2-year residency programs, but they're more so preventive medicine geared. But most of them standard, it is 3 to anywhere to 7 years. And then there's subspecialties, and you can keep adding up more fellowships and keep training. I think the longest residency that I know of is a neurosurgery residency. But see, this is a line, a straight line, but the path to medical school, as you may know yourself as a pre-med student, it's not always linear. I know mine wasn't either. I don't think anyone's is. Even though I did go straight from college to med school without a gap year, but I still had a year in between to do some full-time work. So not too uncommon. People take also gap years in between undergrad and med school to strengthen their applications. It is becoming more common now. But in countries internationally, people actually go into medical school right after high school. So there's no undergrad done. Of course, their educational systems are different, but the knowledge that they learn is mostly the same, of course, because the human body is the same. But you can see here, it's not a linear path. The medical school journey can have some twists and turns. And so this is a graphic I really like from the med school coach. It's actually what I would look at when I wasn't really sure what the path to medical school was. So basically, either students in the United States, they can actually go directly into medical school, into a BSMD or BAMD program. There are a couple in Washington, D.C., near where I live, a couple others as well upstate. Or you can do the traditional pre-med undergrad. That's what I did. Then some students do a post-bac or a master's program, but eventually they end up taking the MCAT. Then they start medical school. This is actually where I am now, medical school M1, which means first year M1, second year M2. And then you have to take the first licensing exam. There are a total of 3. There used to be 4, but now there's 3. So it is a USMLE, actually stands for the United States Medical Licensing Exam. So it's very important to have this awareness that the exams don't stop after the MCAT. They continue on, and that is why we really need to develop that resilience and that work ethic to carry you on all the way up to the USMLE Step 3. But after the Step 1, you actually start clinical clerkships, and that is actually the second phase of the medical school curriculum. I haven't started yet, but will do after I pass Step 1. After that, during that, actually, during M3 year-ish, you take Step 2. Now, there's no longer a Step 2 CKNC, it's just called Step 2 now. That was the 4th USMLE step exam I was talking about, so that's outdated, but it's just called Step 2 CK, or this is the clinical knowledge one. Just FYI, CS used to just be like a clinic simulated patient stations, but that's no longer the case anymore. Then you start the intern year or internship, and PGY stands for postgraduate year 1. That is basically the first AKA right after you graduate medical school, you do PGY 1. And then most people take their USMLE Step 3 exam either at the end of 4th year or during their residency. But even after Step 3, exams don't end, because to get board certified, you need to actually renew your medical license or board certification. Let's say you do internal medicine. You actually need to take a board exam every 10 years. So I find that very, very interesting. So the exams never end. Of course, it gets easier as you keep practicing. Now, let's talk about the transition from undergrad to med school. And specifically, I'm going to be talking about the pre-clerkship curriculum, or the first 2 years, the first half of medical school leading up to the USMLE Step 1 exam. And so that's going to be the basis of our sort of med school boot camp. So here we are going to basically, I'm sure many of you have seen a lot of TikToks or a lot of Instagram reels about medical school workload. I'm sure you might have already heard of these analogies, this fire hose analogy on the right here, that this is just what it feels like, the amount of content that's just always being thrown at you in medical school. But I would say that's very sensationalized and a very popularized analogy I don't necessarily agree with, especially as someone who has gone through a year of med school. I would say though, of course, it's not unfounded. There is a lot of material for sure. What I would say is it's like not every medical school is different, of course, but mine specifically has an exam every 3 to 4 weeks. We have different organ system blocks. And so I would say every block tests you on an amount of knowledge that's equivalent to an MCAT. So it's like taking an MCAT every exam block, sometimes a little more than that amount of content. And how I measured that is basically for the MCAT. I'm sure I talked about this in my MCAT prep video, but basically, um, there is an Anki deck, which I'll talk about Anki later, but there's this like flashcard deck that has about 5,500 cards specifically made by someone a few years ago. And so one of my exam blocks would have anywhere between 5,000 to 7,000 Anki cards. So that's just sort of I know people sometimes take years or 6 months to study for the MCAT, but here you sort of build up your capacity and you only have like 3 weeks to prepare for the exam block. So you have to really start preparing for your exam the first day. How I would compare that to undergrad is basically in undergrad, I could sort of, I'm sure, and this is something all my med classmates say, that they could sort of have gotten by just starting to study for the exam, like maybe a week before, maybe 3, 4 days before, maybe even 2 days before an exam. But in med school, you really have to start studying for the exam the first day you get the material. And over time, it becomes easier. So there is, of course, an increased volume and complexity of the information, but once you get used to it, you'll realize once you already have that foundation, that bachelor's degree, right? And so I was a bio major, and that does make things a little bit easier, but not necessarily. I'll explain why. Because as a bio major, you do take a couple of upper level classes, like I did. I took endocrinology, I took microbiology upper level classes, but really that entire semester's worth of information was covered in just like a day or two of med school lectures. So really, I would say that just helped me for a day or so, and then everyone's back on the same level playing field unless they have a PhD in immunology. And of course, we don't learn as much material as a PhD in immunology would for immunology, but that's just an analogy I'm thinking of. So instead of the fire hose analogy, I want to propose something called a pancake analogy. And basically, this pancake analogy essentially is like, I would describe med school as having to eat 4 pancakes every day. And 4 pancakes is a decent amount of pancakes, and eating 4 a day is doable though, right? But if you don't eat your pancakes one day, you have to eat 8 pancakes the next day, and so on. So if you don't eat any of your 4 pancakes every day, you have to eat like that becomes 20 pancakes on at the end of the week, right? So that's not doable. So basically, medical school teaches you that you have to make sure to eat your pancakes every single day. And that's the only way to make it doable and digestible. And so that's why procrastination is really not something that I would recommend, or some people try, some people do it, of course. Everyone is different, but I would say for the vast majority of medical students, they are starting to study on the first day that that material is presented to them, memorizing it as though the exam on that material is the next day, because the next day you will have another 4 pancakes to eat. So again, it's not like the material is super, super hard to understand if you're able to memorize it in one day. It's just, it will increase in volume if you don't, if you're not on top of things, basically. And so that's why you have to have that sense of responsibility and that motivation to keep doing it every single day for a year and a half, or however long your pre-clerkship curriculum is in medical school. And it ranges based on every med school there is. There are over 150 med schools in the United States, and also their DO schools as well. And there are also differences in teaching methods in med school. They do a lot more case-based learning. Of course, I love med school because it's all very clinically relevant information, whereas in college, when I was a neurobiology major, I still had to take like zoology prereqs or ecology, which is not something I was personally interested in. But I am learning things that I'm interested in, and it's more clinically oriented. And for DOs, DOs actually have to take another type of licensing exam for the Doctor of Osteopathy degree. They're still physicians, but it's called the Comlex exam, COMLEX. But they basically test the same material that's tested on the Step 1 exam. And many of my DO colleagues, they take the USLB Step 1 as well, but I'm personally enrolled in a MD program, which is why I keep saying Step 1, but it's also relevant to the Comlex Level 1. Also, my basically my professors, they are doctors. They're either MDs or DOs. My preceptor is a DO. For my clinicals, my some faculty are like dietitians when we have like nutrition-based lectures. Some faculty are also PhDs, and so I'm very humbled when they teach us our biochemistry lectures. And so during this time, sometimes we neglect self-care. This is something that Dr. Chimo always stresses every single lecture, almost every lecture that we have at teleshadowing, because it is a very long marathon. Because another analogy that I've heard, on top of on top of the pancake one, and this is also very pretty real. Basically, medical school has also been described as it can take all the running that you can do to keep in the same place. So it's kind of like being on a treadmill sometimes. Of course, because some days you have 8 pancakes, other days you might have 2 pancakes to eat. So it's not like every day is 4 pancakes. That's just the best way I can summarize it now. And I really never understood this until I actually had lived experience. So it's really hard to describe it until you're actually in it, but it's the best way I can do it until you're also future medical students and telling me about how your wonderful experiences are. But it's all very doable. And establishing really good self-care and well-being habits during undergrad, high school, or in your gap years before medical school is very important. And I would say prioritize having habits like that over like self-studying or pre-studying before med school after you get accepted. So the reality of med school, right? So I see a lot of amazing like things on social media about how wonderful medical school looks. But really you can see this picture here. The expectation is that it's super clean, that said it's super aesthetic. You're able to get a lot done, you're very productive. But in reality, honestly, I see I mostly see this in the library. And it's not that it's super bad. I mean, of course, sometimes if you are in your early 20s or you don't have uh, those self-care habits established. Even if you do, sometimes you do need that extra burst of caffeine or energy drinks. So again, remember that medical school is graduate level coursework. So it is different. We do have like credits. Like I took 25 credits my first semester and 23 credits my second semester of med school. But this is graduate level work. So of course the credit hours in undergrad are on average 15. So it is a little bit more. You do want to manage your expectations because this is relevant to like if you're even going to pharmacy school or PA school, doing a master's program, going to law school, etc. This is a graduate level coursework, and a lot of time and energy needs to be had to really be successful. Oh yeah, and here it is, where the comparison between the 23 to 30 credits per semester in med school versus the undergrad level. And also, I'm on before I started med school, I didn't really understand how someone can study for 6 to 10 hours a day, eating their 4 pancakes. And also, what does that 6 to 10 hours actually consist of? Because you can have like 12 hours of studying, but it may not be as effective as maybe different strategies you can employ to take 6 hours instead. So I did a lot of research in kind of understanding what are the best ways to learn and the most efficient ways to learn material, and it really ranges from person to person. So it's another tip I would give to someone who, in the summer, preparing before medical school, learning how they study, learning how they learn, learning how to learn, and learning how adults learn. Because the way adults learn is very different from how children learn, because our brains are wired differently. So what does that exactly consist of? It can consist of practice questions. It can consist of rewatching lectures at 2x speed. It can really vary. It can range from mind mapping. It can range from people have these coloring books to remember different anatomical regions and landmarks and figures and muscles and veins and arteries, where they're just coloring in their coloring books for anatomy, which is something I've done is very helpful. Um, a lot of practice questions, a lot of mind mapping, a lot of making sort of big picture understanding of the material to understand where you are and why you're learning something. And a lot of, and of course, what's very popularized is Anki. Anki literally means to memorize in Japanese, and it's basically a spaced repetition flashcard app that a lot of people use for MCAT studying. And I would say it's very good to learn how to use it because in med school, a lot of students end up using it even if they didn't use Anki in the past because it is really a very very efficient way to study in med school. Anki is not something I use every block. I kind of change how I study every block, but it is not something I'm averse to or don't use. I use it as a tool, or maybe I make flashcards and then I'm just like, oh, I made the flashcards. So I don't really need to go over them again, or sometimes one topic might come easier to me, but harder for another block. But it could be different depending on what an individual's strengths is and what they're interested in. And also this question, this is something I alluded to earlier. How do medical schools really condense a semester's worth of information and of undergrad content into one day? So what I mean by that is, like I was saying before, I took biology of cancer in undergrad. And that was a class that I spent 16 weeks, whole entire semester learning about the biology of cancer. And this was I think October of my first year, and I was reading the syllabus for this new block that we were entering to learn about cancer, and I was like, oh, I took a class, I'm all good, I see the keywords, I'll be totally fine for these 3 weeks. What happened was really my class was summarized in maybe 2 or 3 slides, or maybe just 1 or 2 lectures of the day's lectures. So every med school has a very different way of doing lectures. Some lectures are mandatory, recorded, not recorded. Sometimes lectures are 8 to 5. Sometimes lectures are for 2 hours, and then they leave you free for the rest of the day. So my curriculum, we just have a lecture for 2 hours a day, and then sort of a case-based learning, active learning session for the other 2 hours of the day. So total 4 hours of structured learning, whereas the rest of the day is unstructured and left to us, whereas other medical schools sometimes structure it for you. So it's really medical school curriculum dependent. So getting back to this point, how do medical schools condense it? Well, remember, first and foremost, we have a foundation built already from our bachelor's degrees. And remember, we're just learning big picture material and we need to learn more of it and as much as we can to serve our patients. So it is true. It is actually a very true statement. I never believed this until I started med school. I said, there's no way. This is obviously an exaggeration and like a sensationalization of how medical school is, but it's really not. And it's the truth that it really things can be summarized in just a lecture or two that I spent an entire semester on. But really, again, it was because I spent that entire semester that I was able to digest how I learned that day's lectures. And of course, there are social media and medical school student influencers who sort of course, romanticize it, and that's their way of maybe, creatively expressing themselves. But I wouldn't say social media is the most realistic view or perspective of how medical school is like. Of course, everyone wants to glamorize and show what they want to show on social media, but I would caution you against comparing yourself when you are a medical student yourself to what you see on social media, because people are just posting the highlights of what their lives are like. So now let's switch gears a bit and learn a little bit about how humans actually learn. So I'm going to be going over some theories with you. They are kind of word-heavy slides. I tend to avoid word-heavy slides, but I promise you'll be quick and painless. And I got this from the Florida State University Medical School's website. So a big shout out to Miss Nancy Clark. She actually has a master's in education, and so I found her. She had a couple of PDF documents that I read, and I'm summarizing it in these slides for this section specifically on how adults learn in the context of medical school and what makes it most effective for medical school learners and future doctors. So this is called instructional design. So what comes to mind when you think of instructional design? What exactly comes to your mind when you see the words instructional design? Sounds pretty engineering heavy, but really it just means how your classrooms or how your instruction, how the way you are presenting information is designed, because there are different ways to present information based on your audience, right? For example, when I prepare teleshadowing sessions with the medical director's team, I tend to condense material that's not really relevant or out of scope, like I say, for undergrad students. And I try to make it a little bit easier to understand, or I give big picture views and just overall generalities. Sometimes I generalize because I know that you're all going to be learning it in med school in more detail, but I just like giving brief overviews because my audience is is undergrad students, not med students. If it was med students, it'd be a different story. I'd go in much more detail. But let's get into it. So according to a lot of different studies, I've gone into this. The best instructional design for medical schools specifically, number one, they have to be effective. Basically, they have to already have in mind the toolkit of the learner in terms of their knowledge, skills, and attitudes. That's sort of why we have the MCAT to sort of have that baseline understanding, that baseline knowledge of what's most effective for that learner. And the next thing of like, let's say you're planning like a lesson plan for someone. It needs to be efficient as well. It needs to require the least amount of time necessary for the learners to achieve the objective. Like an objective meaning something that's like measurable, observable. Like what do you want the learner to achieve, or what do you want the learner to learn by the end of it? That's why I always show outlines in the beginning of my presentation, so we sort of know what direction we're going in, and then we take a quiz at the end for your certificates. So basically, you want to fit the goal of the training and teaching. You want to articulate it, of course, as well in the beginning. And you want to communicate the intent to the learner so the learner is primed to learn specifically what the instructor wants them to learn. And you also want it to be appealing. You want to be able to motivate and interest the learner. Some ways that my med school does it is we have, usually a day or two before we learn, like let's say Huntington's disease, they actually have a patient come in with Huntington's disease or a family member affected by Huntington's disease, and talk to us about their experience, their journey, and they're just a regular Joe, just with a disease. And they come in and talk to us, and I talk about it in sort of a sometimes a layman manner, sometimes I talk about it in a very high level manner, but it's just a patient talking about their life story, living with the disease. And so when you know the patient, when you know a face behind the disease, I would say that is one of the most effective ways to really learn, because that motivates me personally, because it's the patient care. That's why I'm going to medicine. That was my motivation to heal patients. So when I see the patient on the other side of the end, when it really helps me see the point of the textbook, when the textbooks get very hard to keep reading, this is what really motivates the learner. This is sort of how our medical school curriculum has done it. And it sort of keeps me persevered and motivated to keep going when I keep thinking about, oh, this was Miss Jane Doe who had Huntington's disease. I really, really want to learn about it a little bit more. And finally, the instructions or the class itself should be enduring. Enduring is basically meaningless. It should be stored in your long-term memory. It should be accessible and applicable in the future. So that Huntington's disease example I gave you is from almost a year ago, and I still remember it. Even though it was a long time ago, I didn't take notes. I just sat and listened to a patient talk about their experience with Huntington's disease. Did not take notes, just listened to her lecture. I still remember what she was wearing. There was an emotional attachment to this person's story, because Huntington's disease is a hereditary disease. It's genetic, and we're going to actually be learning about Huntington's later this month in our biochemistry month. Um, so I'm excited for that, and I won't spoil it for now. How you can apply adult learning theory. Basically, if you're the instructor, you want to explain why specific things are being taught. So we are given clinical context, like the clinical relevance behind why we're learning something. So last week I was talking about pacemakers, but before that I was talking about the reason why I talked about pacemakers is because there's a lot of anatomy going into the heart and pulmonology and all that, just tying it all together. But then I had to explain why we had to learn about the subclavian vein, the brachiocephalic trunk, the locations, why it's necessary to know where it's located, because that's exactly where a pacemaker is placed. So if you become a cardiothoracic surgeon or a cardiologist, interventional cardiologist, you will learn in much more depth, but having that basic foundation is something that all medical students need to have, and having a clinically relevant context is super important and very helpful as well. And also, the instruction should be task oriented, like do this, do something, instead of just rote memorization. So, for a lot of our case-based learning in med school or team-based learning, they're called CBLs, TBLs, PBLs. It's pretty similar across different medical schools, what they're called, but basically they're task oriented, where basically they have students have, they like, okay, you have a 35-year-old patient who comes in with XYZ, look at their radiographs, what medications would you want to prescribe them? Oh, they have this kind of allergy. So when you have learning activities in the context of the common tasks to be performed, even though we're answering the same questions that we present, but when they're presented in such a way, even if it's just a case study, remember, medicine is open book and also it's team based. So when you're talking with your colleagues and you're in these sitting in tables that are like circly and not like in rows, it helps a lot engage you with in conversation, helps you a lot with understanding the task and also learning just much better. I still remember my first like x-rays I saw and just being overwhelmed, but still very interested and intrigued because I had like a task in front of me. I was able to sort of go through like MRI images. They're sort of like these they're sort of like these sliding scale sort of radiographs that you can look at, and that's task oriented. That kept me engaged when I was learning about it. And also, you want to take into account the diverse backgrounds of learners. Basically, they should be diverse enough that there should be like a visual component, maybe a hearing component, whatever helps you learn best. The curriculum should be equipped to handle it, or at least handle most learning styles, and just give you the tools and resources that you may need. You might not need any of the resources, or you might need all of them, or you might just need one or two of them. But it should still cater to a larger audience and keep in mind the different backgrounds, the different ages, because I have classmates who are over the age of 30, 35, 40s. I have parents who are my classmates. I have nurses who decided to go to medical school to have an expanded scope of care. So, of course, we have professionals. I also have like a classmate who's a lawyer. So, um, this is a very diverse background of excuse me, patients, not patients, of classmates, and we're all different learners, so we're all learning in the same classroom. So accounting for all that is important. Another thing, adults are self-directed, whereas children need to be directed, they need to have their hands held. But of course, as a medical student, you are self-motivated. You have gone through all the hoops and um, all the challenges that life has thrown at you being a pre-med student. And so as a learner, you should be also intrigued to learn and think things through yourself. And so that is why we don't always have like a doctor preceptor looking at us or staring down at us when we are answering questions during our case-based learning sessions. We learn it ourselves, or we explore other resources if we're not sure. We ask questions, we ask each other. Sometimes someone knows more about a specific topic than I do. So, and then they come and check, and they come and like basically visit us and check in on us and provide us guidance when we make mistakes. When we make mistakes, I would say that's the best way, the best time I learn things personally when I make mistakes uh, during these types of exercises because they're low stakes. They're not even graded. Many different medical schools have now transitioned over to a pass-fail curriculum as well. Mine is not pass-fail. But many, I would say a lot of medical schools are now pass-fail because our step one exam is no longer on a numerical score, it's just pass-fail. So that's a huge perk and helps reduce anxieties related to learning because our goal is not to get good grades or I wouldn't say someone who gets a 80 on exam versus someone who gets a 70 on exam and they both pass. That doesn't necessarily mean one will make a better doctor than the other, just saying someone might be a better test taker than the other. So that's sort of why medical schools have shifted away from numerical scoring and ranking students against each other because students should not be competing with each other. They should be helping each other learn. Just like I mentioned that story of students helping me learning from different peers, etc. Now, principles of andragogy. Andragogy is basically how adults learn. Pedagogy is the art or style of teaching or learning, but andragogy specifically is the way of learning in adults. So adults specifically, and now most medical, all my classmates are adults. They basically need to be involved in planning and evaluation of their instruction. They also need to be able to experience, like I said before, having the experience of mistakes as well. It really helps a lot with different learning activities in the future. Also, adults need to be interested in learning the subjects that they're learning. So that's why getting to med school is not the super easiest thing in the world, because people actually, admissions committees really want to see and check your motivation for going into medicine, because they don't want you to burn out halfway through. So it's for your best, and also for really society's best, to make sure that they're recruiting future physicians who know why they're going into it. Um, and also, I've seen that some of my classmates who have also been patients, they are much, or and when we're learning about the disease, for example, I have a classmate who has type 1 diabetes. So during our type 1 diabetes lecture, she was actually much more engaged. She was talking actually about her experiences with the rest of the class, and it helped me learn a lot as well. But I could tell that she was much more passionate about it, because it was, of course, her own disease. She was learning about her own disease. Or there are classmates I have who have, during our cardiology unit, who have family members who've suffered from like a heart attack. That's very common, or a stroke during our neuro unit. So different students might find more immediate relevance to their personal life, or to what they're interested in. And so that might help them learn as well. And instead of just giving you content and having you regurgitate it, uh, it's better to just ask questions and make the learning more problem centered. And that's why we learn a lot of case-based studies rather than just content oriented. And you can go over the content. Of course, content is the basic foundation, but what really helps something stick is asking a question instead. And so there's different actually levels of learning that help make it much more engaging. And finally, I would say how someone experiences learning. So the best type of learning actually happens when the subject matter is relevant to the personal interests of the student, like I mentioned before. Learning, even if it's something, really in med school, the best, one of the best pieces of advice I've heard is get comfortable with being uncomfortable. The reason being is because sometimes you might be learning something that's completely opposite to what you thought was the truth. When we're learning more about social justice and the historical legacy of the healthcare system. So, learning things that might be threatening to the self, like new attitudes or perspectives, actually it helps better. It's much easier to digest these things when students just feel much more safe in a safe learning environment. That's basically what that says. And self-initiated learning is the most lasting and effective. So self-initiated learning is incorporated into my curriculum specifically through we have this um, FRCT research project, and that's basically a requirement that we have to graduate, where we have to sort of initiate our own research or become a first author on some kind of research project. And that's sort of a project that we tend to initiate ourselves. Sometimes it's given to us, but we do pursue what we are interested in personally. And that tends to be the most lasting and sometimes the most grueling of activities. Sometimes research takes a couple of years. So when it's self-initiated, the student stays self-motivated to continue through it. And one of the best ways to learn through experiential learning is simulated patience. And so you can see on the right here, this patient, she is of course a real person, but she is an actress. And so we actually have something called an OSCE and OSCE, and that stands for Objective Structured Clinical Experience. Basically, it's a standardized clinical patient that you have, a standardized patient that you have in a lab or in a basically controlled environment where you have actors and actresses. Sometimes they're professionals, sometimes they're retirees. They don't really tell you who they are, but they act like patients. Sometimes they cough like patients. Sometimes they give you lab results like real patients. And so you have to come in and kind of role play, but and when you role play, things really stick very, very well. So I've had a couple of these experiences, and I still remember in vivid detail every single one of them. We actually receive feedback on them, on these experiences as well, and that is actually considered the most effective way. You learn by doing. That is how adults ultimately learn. And so that is the main takeaway I want you all to take from this lecture. You learn by doing. That is why shadowing experiences in person is so important. You learn a lot by doing, by giving patients. I know in undergrad, when I was a pre-med, I would just be delivering like water to different patients, but I would be learning from their stories. I would learn by doing. I would learn by giving some patients like warm blankets when they needed it. Even doing these smaller acts of care were still very vital to my learning of the patient, the real patient experience. And in medical school, of course, in the first 2 years before you actually start on the wards, like they say, or the real clinical rotations, the first 2 years we have this built in where you have simulated patients. And we also have real patients that we do like history taking on, but this is sort of how they start us off, having simulated experiences in low stakes environments that really help us learn. Because when we know that, nothing will go wrong, no one's going to die under my watch, you can actually flourish and grow much better by having simulated patient experiences. So, how to actually learn? Like, how does your brain actually learn? That's sort of what cognitive learning principles means. How does the brain learn and absorb and retain information? Actually, the learning activities need to provide many different representations of the content. So sometimes our professors, they give us like 3 different diagrams showing the same thing, but maybe one of them sticks with me, and the maybe diagram B sticks with my friend. So what I really like about it is sometimes through spiral learning, I'll talk about that in an upcoming slide. You see something more than once, but in different contexts, and that actually helps you remember the content much better because you're seeing it represented in different ways. And also, content should not be oversimplified, and they should also be context dependent. They should be supported through context dependent knowledge, and that's how real life really is. You don't want to, of course, simulate very oversimplified scenarios and not prepare the future doctors of tomorrow if there's another pandemic in the next few years, or could be any time because the next pandemic is not a question of if, but a matter of when. Instruction should also be case-based, like I've said before, and emphasize building upon new knowledge and not transmission. You're not like basically our instructors, what I find really effective is that they hold our hand through the process sometimes, but they make us answer the questions. They will not answer the questions for us. They'll ask us when we ask like a question and they're like, well, based on the patient's labs, what are you thinking? They ask us our what's going on in our brains, and sometimes that can help unlock us and lead us to the correct answer. The best analogy I can use for this is like an escape room, because in escape rooms, you're not, sometimes if you need a hint, I know I use hints sometimes, but let's say I'm given a hint in an escape room and I'm not actually given all the information, I'm just given like a hint. And so these hints help me remember that experience because I learned by doing. I did trial and error, and that is the best way I was able to learn. Whereas if I was just told, oh, the secret passcode is XYZ, instead of figuring out, oh, you should look behind you and figure out a 3-letter combination. And that's much better than just giving someone information because they learn by building upon the knowledge that they already had. And also, I'm going to show you all a figure of what I mean by knowledge sources should be highly connected rather than compartmentalized. Because in medicine, you might be learning one thing separately, like you're learning about like brain anatomy, but remember that is highly interconnected to the rest of the body, or the cranial nerves. It is very connected to everything else, to derm, of course, we have the facial nerves running through us, and of course they're innervated by a cranial nerve, but they're highly connected to many other aspects of our bodies. So, this is actually taken from my medical school, University of Maryland School of Medicine's Foundations Content Map. And I'm showing you here this spiral that you'll see right here. This is actually how, and this is kind of complicated. Basically, it's like, think of it as a subway map. Now, this is sort of my first course of medical school, if you will, that I had every single day, just had one class. But it changed in blocks. So there's block one, block two, block three. Basically, before I could enter this world, I had to pass the first anatomy exam. We learned anatomy. We were in a cadaver lab for a couple of weeks, and we did all thoracic anatomy. Then we switched over to DNA repair, enzymes, chromatin, gene expression, and inheritance. And this is actually how I'm going to be sort of structuring teleshadowing for the next 4 weeks. I'm going to actually be going over all of these topics over the next 4 weeks. But you can see here, I see this material multiple times, even after this exam is over. You can see here, block 2, you have your exam, and then you have another exam for block 3. and so forth. But you can see how the black line genetics, that's sort of a thread that goes through the entire course. In different and it manifests itself in different ways. There are different applications. Cancer is related to DNA repair, it's related to cell biology, and it's also related to genetics. So you can see here it carries over the blue sort of train line. Now, of course, it is a bit complicated, but basically this is sort of what how we learned. And sometimes our professor would just give up trying to explain this, and I sort of understand why she gave up trying to explain this, but I could tell she worked so hard trying to make this for us because it makes sense now. It made sense to me at the end of this course, so it'll make sense to you at the end of this course as well, for sure. And basically, these white dots are our stops, essentially. And you can see it all connects at the end once you see the bigger picture. And the more you see the material, the more you'll be able to master that material. That's sort of what spiral learning is really at its core. And this is not something I'll explain to you in much detail, but if anyone remembers the citric acid cycle, the TCA cycle, where else, where the pentose phosphate pathway, although that's low yield in MCAT, carbohydrate metabolism like glycolysis. You can see here respiration, photosynthesis, cellular respiration. These are stuff that we are familiar with. Amino acids, we've heard of amino acids before in undergrad. So it's all about part of a bigger picture in biochemistry, and this is sort of um, a big picture overview of, and just an example I'm just showing you. We're not going to go over it today, or maybe not ever, but it is scary, of course, at first. But once you understand each piece individually, you're going to be able to put it together and mind map it in your head and see the bigger picture. And that's actually a very beautiful representation of how I personally study in med school, because I don't use Anki all the time, like the flashcard app. I sort of I kind of zoom out from the little details. I don't bog myself down from the little details. I sort of see what is the relevance of this to this other concept? How can I connect them? And what is the difference between these two diseases in genetics or in biochemistry? So you also want to know, like, what are the different diseases associated if something goes wrong, because you want to know what's normal in order to understand what's abnormal. So I'll get off the slide for now. I know it might be very overwhelming, but don't worry at all. We will be learning a little bit about each one, but we will only be learning about what's clinically relevant in our biochemistry month in the month of August. Now, constructivism is basically how you construct concepts in your mind. So for adults, you need to be ready. So the instruction needs to be like concerned with experiences and contexts that make the student willing and be able to learn, be capable of learning. So they should have like a safe learning environment, and that's readiness. And instruction must be structured so that it can be easily grasped by the student. And so that's like spiral understanding or spiral learning, as you can see on the right. As difficulty increases, the more you show something in the beginning, even just a little bit, even just like a preview, and then you see it over and over and over again, it's much easier to retain that information even without like actively trying. And so that is sort of what medical schools are trying to do to make learning easier and faster and more effective and efficacious and more enduring for us. And also instruction should be designed to sort of facilitate extrapolation or also filling in the gaps in your knowledge. So one should also be able to go beyond the information given. And that is sort of where our clinical know-how comes in and clinical judgment and reasoning comes in, because you want to be able to have critical thinking to go beyond the information given. Sometimes you want to, that's sort of, I remember that is sort that's a skill that I first learned in biochemistry in undergrad when I was learning like NMR mapping, sort of understanding IR spectroscopy, if I remember correctly. Basically, I remember thinking my professor would be asking us like also look at what's not there to see the bigger picture. And so that's also very important. Sometimes patients don't tell you or are not able to tell you the full story. So you need to be able to have that analysis, that big picture thinking, those skills to be able to fit puzzle pieces that may not even be there. And so that is what experience teaches you. That is why it takes so long to become a board licensed physician or attending physician. Now let's talk about the ways of instruction. I'll go over this pretty quickly. Basically, if you want to actually instruct someone. You will first gain their attention, like a class of students, you want to gain their attention. You want to inform them of the objective, like what are they going to expect. You want to stimulate the recall of like prior learning, if there's any background knowledge. You know, it's like professors do say, okay, you have to have this reading done before class. So sometimes they might quiz you on that in the beginning of class. They might have like a warm up or a bell ringer. Um, you also want to have selective perception. You want to present the stimulus. Now, maybe the word stimulus is sort of reminding you of some from like the psychology and the sociology concepts for them, Cat. So I'm gonna, and then there's also semantic encoding, and semantic encoding is basically when you're doing the teaching, like giving guidance to the learners. You want to also get, you want to elicit their performance. Like you want to see how students are learning. How are they responding to what you're teaching them? Are they understanding, or is it going over their heads? Ask them if they have questions. And then this is what I want to really emphasize, providing feedback. Adults really, there's a lot of studies that go into this where providing feedback or reinforcement really helps adults improve and learn. So all of medicine is feedback because it is very helpful. So of course there's test scores and there's also feedback, but then there's this feedback loop as a medical student on the left hand, and on the right hand, the feedback does not stop, because basically when you're an attending, you have to adhere to patient guidelines and medical guidelines, and you have to meet, of course, patient quotas, but also you get feedback from superiors as well in that one. So I really want to emphasize feedback. Getting feedback, giving feedback is very emphasized in a lot of different medical school curricula. And also, it's a two-way street. So you want to improve from feedback received, and you also want your curriculum to improve from the feedback that you give them. And finally, as a, let's say you're like, you have wearing you're a teacher, you're a professor, you also want to assess the performance if students are able to actually have retrieval. And then you also want to you also want to be able to enhance the students' retention and transfer through generalization. Now I want to talk about active and passive learning. I know these are buzzwords thrown around very often, and we're actually going to be watching a video about it really quickly from Osmosis that summarizes it. But basically, active learning, if I really had to boil it down, is learner-centered, whereas passive learning is more teacher-centered. So what I mean by that is, remember I was talking to you earlier about information just sort of being thrown at you, like I think, let me see where it was. That information should basically, if it's just thrown at you or you're just getting information sort of dumped upon you, I'm forgetting the actual words, but I'll remember it later. But basically, if you the best way to learn, that's sort of a passive way of learning, right? If you're just given information, you're reading, you're highlighting, that is passive learning. And if you just have like a teacher just teaching you, that is like a verbal lecture, that is considered like passive learning, because that's more teacher-centered. The teacher is giving you information to read. The teacher is assigning you a textbook reading. That is all sort of passive learning. An active learner actually like sort of drives. So I think that's a good analogy. Like basically a passive learner is kind of like the passenger when a car is being driven, whereas an active learner is actually the driver. It's the person who's responsible for their own learning, and it's actually a much more faster and efficient way to learn and retain information from many studies that have been done on learning in adults. So through activities in the classroom, through building on your current knowledge and developing skills to implement it immediately, and also having students to maybe write it down, absorb the knowledge, maybe make flashcards, test themselves on those flashcards, do active recall, remember that information, be quizzed upon it. That's all active learning. I know, and one example of active learning that one of my classmates does is he makes practice quizzes after every week. So basically he does like weekly summary study guides, but the weekly summary study guides are not just like an information dump of like 10 pages of text. No, it's actually question based. So instead of saying the mitochondria is the powerhouse of the cell. Sorry, this is the first example I remembered, I thought of. But instead he would phrase it in a study guide like, what is the powerhouse of the cell? Or maybe a two-step question, sort of get you learning, to get you into the driver's seat. Instead of giving you the information, or instead of spoon feeding it to you, you have to work a little bit harder to get to the right answer, the mitochondria. So this is from osmosis.org. This is one actually very popularized, made by med student who's at Hopkins now, to sort of visualize what active learning is. And so I'm going to actually be showing you all a video, and this is actually Anki, the icon for Anki. But I'll actually just show you here the video now. Let me just reshare my screen. You'd imagine after 150 sessions, you know how to share screen with audio. Let's see. Share sound. There we go.
Like most students, you've probably crammed the night before an exam. And after it, you probably did okay, or maybe you even did well. But did you remember any of what you learned after the exam? One evidence-based way to better remember what you've learned is through spaced repetition, or spacing out your learning in practice of new knowledge or skills. Although this might seem novel, this is hardly a new concept. It was first described in 1885 by a German psychologist named Hermann Ebbinghaus. Here's how it works. Say you plot your attention, or how much you remember of something, versus time. Now you learn that something on day 0. Without reviewing it, the forgetting curve will look like an exponentially decaying curve, which is kind of scary. If you review, or better yet, actively retrieve the material at increasingly spaced intervals after learning it, then the forgetting curve starts to flatten out, and you'll get a lot better long-term retention. Now, the goal here is to review the material at the right time. It turns out that the best time to revisit information that you're trying to learn is right around the time that you would naturally forget it. Since forgetting typically follows this exponential curve, the trick becomes timing your study sessions around it. Practically, this means having more widely spaced intervals between study times for the material that you're more familiar with, and shorter intervals between study sessions for material that you're less familiar with. While this strategy would be effective for all fields of study, it's especially important for students in the medical field, who have to retain key knowledge and skills in order to care for their patients. Kind of frighteningly, one study found that without spaced repetition, after 1 year, medical students forgot up to 33% of their basic science knowledge. And after 2 years, more than 50%. But when students and residents apply spaced repetition strategies in their studying, they significantly outperform their counterparts, with some studies showing close to 40% greater learning efficiency. Knowing about spaced repetition is one thing, but what about applying it? Students, especially those in the health and medical fields, have to remember hundreds or even thousands of bits of knowledge and skills. Because of this, it'd be incredibly hard for them to keep track of when they should revisit each piece of information, especially since each bit of information will follow its own learning curve. And this is why researchers and software developers are using computer algorithms to try and help students optimize their studying. These algorithms help you learn by sorting information based on your responses to questions. So if you get a question wrong, it'll automatically prioritize that information for repetition over the information in questions you answer correctly. In doing this, these algorithms can actually reduce your overall study time by making sure the time you're spending studying for your exams isn't wasted on studying information that you can already reliably recall. One of the best parts of spaced repetition is that it suggests that we can gain a lot by studying smarter, not necessarily longer. With just a little more organization or forethought on your part, you can achieve a whole lot more. That said, spaced repetition means challenging yourself to apply your learning right at the point when you're starting to forget it. And that can sometimes be kind of hard. So just know that if a spaced repetition regimen feels difficult, even frustrating, that can mean that it's doing exactly what it's supposed to be doing. Okay, one final point. In some fields like health and medicine, certain knowledge might change relatively quickly because of new discoveries. So it's important to know the right new information, rather than remembering the wrong old information for a long time. And that's why you should make sure that the tools you use to do the spacing are also designed to help you stay current.
All right, so I'm going to stop the video there and just sort of explain now. Remember I was talking about before when they mentioned the it's hard, right? It's supposed to be hard. So that's why I was saying before it's okay. We have to be comfortable with the uncomfortable because sometimes you don't realize that you're actually getting something when you really are. So just moving forward, really, and that's what I
And
really
finally,
enjoy of med school, the challenge behind it. So this is our last section on medicine being a new knowledge, a new language. Like the video said, there are thousands of concepts really that we need to sort of have pieced together and be able to retrieve at any time. And we need to sort of ground ourselves in the motivation for our learning. So remember that our foundation is our undergrad degrees and sort of how we benefit with the material. So the material is doable, but it's just a lot of it. It's just voluminous. So it becomes doable over time and through practice. And so remember to stick to your foundations and remember that good habits that are developed during college, they can come with you to medical school and just be open to just changing them and shifting them around. And remember that the objective for the pre-clerkship curriculum or the first 2 years of med school is to pass the USMLE step one. So I highly recommend people to incorporate their step one studying as they're also doing their basically their in-house curriculum, or basically in-house is referring to their med school curriculum at the same time. So as you're studying for your in-house or NBME, NBME stands for the National Board of Medical Examiners, as you're studying for these exams every couple of blocks, every block, every system, why not also coincide that with material or like step prep material at the same time? This is actually something that I encourage all of my mentees to do for MCAT studying. Why not just buy your set of MCAT books if you know that you want to go into medical school in the beginning of your undergrad so that you can just highlight and just actually like go through the material at a relaxed pace rather than a rushed pace when you have just like 6 months left to your step one. These study strategies, there are specific ones for exam preparation because this is a standardized exam versus the ones for your in-house exam. Sometimes they might test some details that are not necessarily high yield for the step one. Um, you'd also want to balance short-term and also long-term study goals. Remember that the long-term study goal for me since day one has been I need to be prepared to be able to pass step one. Of course, is a test-taking strategy, and of course, I want to be the best physician I can be first and foremost. And then my second goal is to pass step one, and then my third goal is to, of course, pass my classes, pass my courses. And it's a triangle, it's a trifecta where you can do all three, and you can balance those short-term and long-term goals. Now, resources, right? There are a lot of resources and test prep companies and books. So I'm not sure, this is actually how I felt. Like you can see, usually I try to make my slides digestible, but this is exactly how I felt when I started med school. And I was like, oh, I have so many, this is called third-party material that sometimes med schools provide you with material, like my med school provides me with AMBOSS, some other med schools provide you with UWorld, which is the question bank that a lot of students use for MCAT or SAT, and also it exists for the step one and step two, step three as well. The UWorld does not leave you in the realm of tests, but they are the leading provider of questions. And there's Boards and Beyond. There's something called First Aid. There's Pathoma by Dr. Sutter. There's Anki, you can see in the back. And so much more. I just showed you the most used. There's also something called Sketchy, which is like a visual mnemonic to help remember things. But I would say that all of these should not be, used out all at the same time when you're studying for step one. You should actually be able to navigate study materials and strategies as sort of like for example, when either you are starting to study for the MCAT or you already have taken the MCAT, remember that you spend some time gathering resources that worked for you. So the same principle applies here for the step one. But I would say that the most used and I would say 95% of medical students, if not more, vast majority, almost unanimous majority use something called the first aid. This is just one tool. I use more than one, but this is the one I've been using since I started med school. So basically, whenever I would have a lecture in class, I would basically annotate in my step one book what I learned, how I learned it, so that when I'm actually doing my step one prep, I'm going to be opening my book and it's already beautifully annotated, and I'll remember, oh, I did learn it before, and that sort of helps me, sort of get through the amount of material. So there are, of course, there's of course going to be a trial and error process in finding what works for you, but there are a lot of resources and also understand that I'll go over my mistake later on, but basically you need to be able to manage the information overload. Remember from that slide I showed you of all those different resources, and avoid burnout. You should be able to balance study schedules, have a study schedule. I use Google Calendar to manage my schedule. Of course, eliminating and reducing social media use. I know a lot of my friends, they tend to like they deactivate their like Instagram and TikTok until the weekend after an exam, and then they deactivate it again when the new block starts. So remember that the rest of the world, you're not. I know people sometimes we all have FOMO, fear of missing out, but trust me, you will not. You're not going to miss out on much when you reduce your social media use. And what I wanted to mention before I talk about the other points is budgeting appropriately because this third party material and these resources, they're expensive. They can get expensive and the cost can add up. Just like for the MCAT prep, there's the AEMC official material. For the MCAT, there's like Kaplan test prep books I have to buy, also UWorld. So it was at least like a $500 investment. Also, the cost of taking the exam that also exists. Now, there are, of course, scholarships and financial aid available for those who need it. School to school, it depends. But when one is choosing the best materials, they want to try, using trial and error and seeing what works for them and investing in one or two in the early stages of their pre-clerkship curriculum before really delving in deep. So I would recommend, for me, I would say if I could go back, I would say I would invest in something called boot camp, which is basically like a newer resource that I wish I used in first year, but I'm going to be using it in second year to basically coincide with my in-house lectures. And it sort of summarizes your lectures and tells you what you really need to know and the clinical relevance and helps you prepare very well for step one. Also has like a question bank. Of course, you want to study with questions. Um, and then use different techniques for effective memorization. Now, it doesn't necessarily have to be like what everyone else is doing. What everyone else is doing around me, they use Anki and for med school, but it can also be in the form of mind maps. It can be in the form of making questions. It can be in the form of making practice test questions for yourself and quizzing yourself. It can be in the form of teaching others. For me, it's teaching others the material that helps me remember it a lot. It could be in the form of making very beautiful notes. Now, of course, I learned the hard way that making beautiful notes, that like I used to in undergrad, did not work very well in med school. So my mistake was I kept continuing a method that I knew wasn't very effective for me. And so I would spend like 12 hours a day studying during the first couple of weeks of med school. And it was not effective studying either. So it was like I was feeling super, super tired, lethargic from studying all the time. And it was not even effective studying and I didn't know what I was doing wrong because it was about transition. So that's a learning point for me is like I was just very stubborn in wanting to continue with this method that didn't work of studying when I was like, oh, I want to make my notes very beautiful, very pretty. I'm going to have my iPad. No, like it's okay to change the way you learn and the way you study based on the material that you're learning because how I studied for my neuro block is very different from how I studied for my anatomy block. So being open-minded to changing your study habits and study tools was something I wish someone told me to do before I started medical school. And how to choose the best materials, well, definitely do your research. Go on, there's a lot of forums like Reddit, and also the first aid book I would recommend you all to get. And then the first aid book, the 2024 version, actually they've partnered with Boards and Beyond as well. But in the back of the book, it actually like ranks all the other types of like material I was showing you in the previous slide. Like it ranks it like it gave Pathoma like an A+ rank like a rating and Boards and Beyond like a A-, and Amboss like an A, so that way you're able to actually comb through it because there's a lot of resources out there. This is just the tip of the iceberg. What the more like famous ones are, the more buzzwordy ones, and of course the sketchy. I can talk about it all day long. There's sketchy and osmosis and dirty medicine and nerd ninja medicine. There's a lot of free resources out there as well. So definitely budget appropriately and see what's free, what your upperclassmen recommend because every med school's curriculum focuses on different things and prepares you for a step differently. I would recommend talking to your upperclassmen, forming connections with them, and they will actually help you best and tell you exactly how and give you a good roadmap and talk to different people because people prepare for things differently. Just like someone's MCAT journey wouldn't be the same from your own. So that's the best advice I can give for that. And beyond medical school, you need to make sure that you're building your support system despite studying all the time. Remember that it's really important to have a support network available to you with your family, with your friends and peers. Use resources like academic advisors and mentors. Your Office of Student Affairs might have a very might have check-ins with you, and I know mine does, and we're meeting. We meet regularly for funsies. And also just building good peer networks or study groups, because remember, you're studying with future doctors. You could be studying within a future orthopedic surgeon or a cardiothoracic surgeon. So just being nice with everyone and kind and respectful to everyone, that is a basic human dignity thing. That's not if you're a med student or not, it's for everyone. Also, having resilience and coping skills, because sometimes you might try your best and uh, you may not see the results of that, and you will learn and through trial and error. It's very important to check in with yourself. I know that it's okay to ask for help. It's actually a sign of strength. It truly, truly is. I was mental health first aid certified when I first learned the importance of mental health, and it's okay to ask for help. I know that a lot of medical schools, they have a very big emphasis on well-being now, and helping you seek out the help that you need when you need it. And also just building on the resilience that you've already shown the admissions committees that you have through challenges and adversity, because medical school is not a walk in the park, but it can definitely be much easier when you have a support system, and you have that when you have healthier coping skills, like I mentioned in the beginning of the presentation. Like having healthier ways to cope with stress before starting is a really great way to manage your time and sort of transition into adulthood during undergrad. So focusing on these healthy habits, because they say that doctors make the worst patients. So understanding that when you're telling your patients to have good sleep, are you sleeping 8 hours a night as well? So these are some questions that I ask myself. Before I preach it to my patients, I want to make sure that I'm practicing it myself so that I walk my talk. So, Dr. Shima always goes over this. So I'm going to be summarizing self and well-being, right? There are four main domains that Dr. Chima always emphasizes. There is physical health, like making sure you're exercising, you're moving, you're doing your 10,000 steps a day, and I'm working on that. Of course, I'm not doing that just yet, but I am hopefully going to change some things around and do that for my second year. Of course, you are working on you're exercising your mind every day. You're using many of your brain cells, and your neurons are constantly being challenged and opened up because of all the material that you're memorizing and learning and understanding and applying. And of course, there is emotional intelligence through your heart, as in sort of making those connections with others, seeking camaraderie and having good companions throughout it all, through whether it be your family or friends or colleagues or mentors. And also spiritual intelligence through your conscience and through like, are you, because how will you be able to fill other people's cups if your own cup isn't full? So filling your spirit can be done through a variety of ways, through praying, through meditation, through journaling, through really grounding yourself so that you stay motivated when times get tough. Remembering your why is very important. And finally, beyond med school and beyond its studies, we are also juggling, and it's almost like there's not enough hours in the day, but really, eventually, you do transition into doing extracurricular activities like joining interest groups. Like, I'm on the board for my internal medicine interest group, um, or different initiatives around medical school, whether it be extracurricular activities or community service. In fact, a lot of medical schools require community service, so I have service-based learning and where I tutor middle school students in Baltimore. So that's a really fun and enriching experience to help encourage them to go into STEM fields. Also, research. Research is truly the academic currency of medicine. I'm going to repeat that again. Research is the academic currency of medicine for students who potentially want to match into more competitive specialties for residency. And that's just a reality and fact of the matter. And so having that awareness earlier rather than later is very important if you know that you want to become a surgeon, or if you know you want to become a dermatologist or radiologist. Now, the thing is that these are not harder specialties per se. It's just that there are less residency spots for them, which makes them more competitive as a result. So, because there are fewer residency slots for these types of specialties that I mentioned, that's what makes them a bit more considered, I guess, as an extension, like more prestigious, because sometimes they pay more, like orthopedic surgery, but there are less less slots. So because that sort of makes it more competitive. And so you're competing with other medical students from a bunch of different other medical schools. And what makes you stand out is through this academic currency of research. Because being able to juggle research on top of your academic commitments really shows that you have your time very well managed. And at the same time, many of my classmates are also shadowing other specialties to sort of lock in what they're interested in pursuing. And at the end of the day, then we are given this well-being presentation and then told to sort of have a proper work-life balance. And that's not always easy to achieve. Sometimes work and life might, not have a big differentiation or distinction, but I would argue that it's just a little bit of investment of your life to have a better lifestyle. It depends, right? Some people, if your work is your passion, then why you're separating it from your life? But I think what life in this context means is time for family, time for friends, time for cooking, time for eating, time to yourself, time to watch or binge watch a Netflix show. So, work-life balance, of course, we are not robots. We're not studying 24/7. There's always time to do the things that you are passionate about and love, just like I've been able to continue teleshadowing and making hour-long presentations every week. So it's still possible to make time for the things that you're truly, truly passionate about. And at the end of the day, I want to leave you with how a medical student's motivation for learning is not just to get good grades or to pass our exams, but it's also to have some mastery of the subject that you can actually take into the clinic as well. So the ultimate goal of medical education is really having some mastery of content that we can explain to our patients for, that we can draw graphs and explain to our patients about when they ask us questions, when they ask questions about why you're giving me X treatment plan instead of Y treatment plan, and sort of explain to them in terms that they can understand best the pathophysiology, sometimes our clinical judgment, sometimes telling them to seek a second opinion, but still being informed enough to be able to treat our patients and give them the best possible patient care. And the role of medical professionals as good Samaritans as well, and keeping our why in focus to avoid burnout. So one really good piece of advice I was given was when you start medical school and you're feeling really tired, you're close to burnout, or you are feeling burnt out, it's very common. Open up your medical college application and just read your personal statement. And reading it should help you feel a sense of motivation and remember that time when you really, really, really wanted to get into medical school and and really helps you focus on your why, because that personal statement is your why of why you wanted to go into medicine into the first place, even when times do get tough. For me, as I want to go into medicine, and I'm really looking forward to my third and fourth year because that's when patient rotations start. And that's what I'm most passionate about. So that's sort of my why, and it might be different for other people. And so I have a picture here of what might it mean. It's a study. What might it mean to embrace emancipatory pedagogy in medical education? So this is more so diversifying medical education, because in the past there would be a lot of medical injustice towards patients of color because doctors were not trained on seeing different medical conditions on different skin tones. As a result, a lot of things were left undetected. And as a result, a lot of people of color specifically were maybe unintentionally even were did not have much equitable care provided to them. And so nowadays we are striving towards more health equity and avoid and reducing health disparities through the social determinants of health, through a more holistic lens, and treating patients. And that's what I really appreciate in my med school curriculum and lectures. Like I see a lot of diversity in the patients that I see. When I'm seeing different like dermatological conditions, I'm seeing the differences between what it would look like in a Caucasian versus a person of color versus an Asian, and learning the demographics of different diseases, and being very inclusive of all different races and ethnicities and so forth. So that is sort of what I want to leave you all with, is that this is something that medical schools are working on now. And of course, they may be a long ways away, but I believe that the next generation is very focused on social justice and making sure that people are not left behind just because of their skin color. So I will leave you with that thought. And with that said, I'm going to close out today's telechatting session. Hopefully, what I said was helpful to you, or maybe you received a couple of tips on how you plan on studying or incorporating it into your undergrad or preparing for med school, or maybe keeping things in mind for when you start med school. So the link to the teleshadowing quiz is now live. You will need a 70% or higher to pass and receive the certificate for the session. And you can find it on teleshadowing.com/certification. So thank you so much everyone for tuning in and looking forward to seeing you at our next couple of sessions. They will be a little bit more biochemistry heavy, but you will enjoy them, I hope, because I will make them clinically relevant for you in our mini medical school bootcamp. So take care, everyone, and have a good one. Bye-bye.